And now yours truly, I'll be presenting. My name is Dr. Susann Beier. I think I may have not introduced myself earlier. I lead the Sydney Cardiovascular Modeling Group here at UNSW. And I'll be talking a little bit about what we do. So I guess the title of my talk is the Coronary Atlas. And thank you. And some of you mentioned you don't have a machine learning background, so I just wanted to reiterate, we heard it a few times already today, what the concept of an atlas is in this context. So it's a probabilistic map of information, so traditionally applied to anatomy. So for example, if you have the heart and the arteries around the heart, which we are really interested in, the coronaries, or the very first branch of the coronary, which just usually gets most diseased and causes heart attacks, then we can look at those across many different patients and how they vary, get weighted averages, and we get, I guess, a three-dimensional probabilistic distribution of matching points. So there's a value assigned to each anatomic point in the mapping. So as I said, this is often applied to anatomy. We expanded this to include blood flow in the coronaries and have it in a context of demographics of a large population. Now, you might wonder, why do we care about blood flow and why does it need to be in the context of a large population? We briefly touched base of that, but I just want to reiterate that explicitly. So our heart pumps blood flow around, and then with some certain lifestyle choices, people may be more susceptible to disease than others. However, even if people have the same bad lifestyle choices, some people are still more at risk than others. And that's where the anatomy of risk comes into place, whereby the hypothesis is that certain anatomical shapes of the coronary, say with a strong bend, adverse blood flow regions get generated, which injure the inner vessel wall lining and allow plaque to more easily accumulate. So from a scientific standpoint, we're not just interested in the anatomical variation in order to improve and understand segmentation and do certain processes better, but also to predict blood flow and inform disease susceptibility assessment from that angle. So we care about anatomy and blood flow in a large population in order to understand who is more susceptible and why. So the coronary atlas, I guess it sort of comprises a lot of, I guess, research focuses, which I briefly touched base on here today. So first of all, let me talk to you about our data, the data we have. So we primarily work with CTCA images, so computed tomography coronary angiograms. These are contrast, and we have them for normal and diseased patients. So when I say normal, these patients have had symptoms, went in, but then didn't get diagnosed with severe narrowing. So it was not clear why they showed symptoms. Yeah. So this is multi-center, international, and more than 2,000 patient cases, including follow-up data. Now, this is quite interesting because then we have patients who came in at some point of time and then later again, so we can see the disease progression. And of course, the clinical health outcome, what happened to these patients. So some of them may have gone on to have heart attacks, died, have had intervention, and so forth. In terms of anatomy, I mentioned it already, some of the methods we can break it down. We talked about PCA analysis, principal component analyses. We analyze the full coronary tree, including looking at the variation within the population. So how that looks like is that if you have your coronary branches, we can break down what, for example, the bifurcation angle is. So the branch angle between those two arteries going off across the whole coronary tree across a large population. So you can see that not just between the bifurcations of the coronary tree within the heart, we see a lot of variation, but also within the population, we see a lot of variation. Yeah. And then, of course, if you think about the probabilistic mapping again, we can then break it down. Okay, what are the most common shape components? How can we break it down further? And on what spectrum does every patient sits, and how does that inform the hemodynamics or the fluid dynamic, sorry, the blood flow dynamic shear stresses at the arterial wall, which injure the vessel wall lining and are linked to disease. So here, for example, we have the first mode of variation, which appears to be size, for example. On the left, we have standard deviation within a population, an idealized model of the left main first branch of the coronary tree coming down. And on the right, we have the +2 standard deviation, where we can see it changes a lot in size with a power of up to 50%, of nearly 50%. And then the second most powerful mode of variation is curvature. Again, the idealized models on 2 standard deviation on the left and 2 standard deviation on the right, and with the idealized median on the middle. And then the blood flow, of course. So with all that shape knowledge, we can run computer simulations, computer fluid dynamics, if that rings a bell to some of you. We define the boundary conditions. We look at the different, I guess, cardiac rhythms, apply different material models, and look at blood flow markers, which are known to be pathophysiological triggers for the whole tree within the population. So one of the results is shown here, for example, and you can see, and you can imagine within the large anatomical variation, we get a huge variation within the blood flow as well. All right, now that's a lot of data. How do we manage all that flow? How do we assure appropriate data governance, ethical regulations, and so forth? There's huge challenges, as we already mentioned. I don't want to repeat too much of it. I do want to mention our Ahsoka challenge that was run 2 years ago at MICAI. Ramtin is going to talk about that a little bit more just after this talk, where we have gold standard data set made publicly available with 3 annotators, and you can work with that. And we benchmarked a segmentation algorithm against it. So yes, I guess the idea is that we really want to move into considering individual patients, considering what their differences are, and that is only possible with a more automated process, which is faster and reliable, in order to translate it into clinical practice to the bedside of the patient. So moving into patient-specific considerations. Chris mentioned a lot the Framingham risk score. This is the most common, I guess, assessment. It's just 7 criteria, and it's not very specific at all. And in fact, 1 in 4 patients gets misdiagnosed today. So there's a huge opportunity to drive a more personalized consideration, data-driven consideration approach within clinical practice. And by opening this up, we can suddenly have the opportunity to capture much, much more people who are usually haven't been considered previously, which often, I guess, centers around vulnerable groups as well, where perhaps certain socioeconomic cohorts, or I guess with certain ethnicity backgrounds and so forth. So where we also maybe not have as many patients, but as a first starting point, we need to understand how those 2 cohorts, so the standard and I guess vulnerable groups, differentiate in order to then develop better treatments for these vulnerable groups. Surprisingly, one of them are actually women. So women are routinely misdiagnosed in terms of cardiovascular health, and we don't understand enough what the sex disparities are within our, I guess, cardiovascular health. So one of the results our ATLAS data showed is that we have here again the left main branch, an average shear stress measure where likely pathological triggers are generated, with both red and blue being really extreme ends, so too low or too high. And then you can see here, if you remember that little video, we care a lot about the blood supply through the vessels. So the narrower it is due to the disease, the more ineffective, obviously, it becomes, the higher the risk for the patient. So here you can see in blue males and red females, and you can see that, interestingly, even though it's at the same location, the way the disease grows and is located varies significantly. This is for the, on the left is for the left main branch, and for the right is for the side branch. Yeah, so blue males, red females. And similarly, we see the same disparities in terms of the hemodynamics, what I mentioned earlier. So hemodynamics are the shear stress indicators, measures, blood flow measures of disease susceptibility and likelihood. You can see here, females on the left, males on the right, for an average patient profile, and the location is very different. Yes, thank you so much. So I guess that concludes my talk. Very briefly, just the key takeaways. So with this work, it's the first, I guess, comprehensive in the context of a population consideration of the coronary anatomy and blood flow. We have benchmarked segmentation as well as flow characterization and a fully automated pipeline for processing, which Ramtin is going to dive in a little bit more just now. Thank you so much. Question? Yes, please.
How did you quantify the flow in the coronary? How did you get a quantification of the flow within like a particular patient's coronaries?
So we get the routine medical images from clinical practice, and then there's a whole lot of post-processing outside of the hospital room, so to speak. So once we get the images, we segment them, we generate a virtual reconstruction of the geometry, then we apply boundary conditions and run a computer blood flow simulation using CFD, computational fluid dynamics, or machine learning methods. And
how do you know those calculations are correct?
Great question, great question. So there are many uncertainties, and we always have to interpret the results within the uncertainties. So they are patient-specific boundary conditions, right? Some things we know, some things we don't know. Most things are not routinely measured within clinical practice. So how do we then walk this balancing act? In terms of to generate, so to speak, an experiment, which still gives us the answers. It's we apply the boundary conditions we know. We go with the expert recommendation of the considerations, the setup, and we make it in a way that we consider the uncertainties around these assumptions, and we apply it uniformly for the cases considered. Yeah.
Because without an actual gold standard, then you're kind of estimating a lot.
It's a chicken and an egg situation, because you could apply, ideally, in an ideal world, we get patient-specific I guess, boundary conditions for everybody. But then how much can we truly control that, and how much noise does it introduce by then applying that additional uncertainty, right? So if we leave other things constant and we change the things like the anatomy, and look at, okay, if we only change that, what influence does it have? That gives us a lot of great answers already. And then say, for example, we run the same consideration with a different set and a different set and a different set across what we found in a population. And then we have a much better understanding of the mechanisms and how we can describe them. Does that make sense? Yeah? Yeah. Great, thanks. Yes. Okay, I come to you.
Hello there, how you doing? Look, I'm interested in insulin resistance, okay, and I'd like to know how big a contributing factor insulin resistance is to cardiovascular issues.
You're welcome. Insulin resistance. Can somebody, I know we have medical doctors in the room. No, that's an excellent point, and this is, I guess, one of the reasons why we're doing some of this work, because, and of course Louis as well and others, some patient groups, cohorts, some combining factors are currently not considered, and we really have to get the data and I guess the detailed consideration in order to drive a much more nuanced understanding.
I'm not 100% sure, but I think that systematic review that I put up considered insulin resistance as one of the factors. So there's a systematic review. I can give you the details for it after the talk. I don't know what the value is, but the systematic review of models that were developed, and I'm pretty sure that insulin resistance was one of the factors that were collected as part of that systematic review.
Okay, thank you. We have an online question, I think. The data set, how big was it to draw conclusions regarding sex disparity? Excellent question. We had 84 females, 43 males, 127 total. Right, yeah. You mean great question, yeah. So we usually compute 4 cardiac cycles, and we take the 4th one to avoid any transient startup effects. And then out of the 4th cycle, you can do many different analyses. So Chi over here, for example, his PhD is partly looking into secondary flow features. So there are many different ways of describing these hemodynamic effects. Some have stronger links to pathophysiological triggers than others, and some are emergent like the secondary flow. Traditionally, there's a strong link with wall shear stress, as you mentioned. You could time average that over the whole cardiac cycle, then you get the time average wall shear stress. You need to think about your time step sizes and things like this. And then I guess you really want to think about, okay, what does it do with the blood profile and how does it affect, I guess, the endothelium at the inner wall lining. So time average wall shear stress might give you a little bit of a better indication of sort of a consistent long-term triggers versus other effects like, say, OSI, the oscillatory shear index. There might be more indicative of, I guess, circulating flow zones, like where we get extremely low, I guess, micro pressure gradients around, for example, behind the disease, and its periphery over the cardiac cycle and the effects of that. Yeah, so we can look at low, high gradient, averaged. Yeah. Yes.
With your model that you developed to simulate the blood flow, those patients from that CCTA, they're heavily influenced by, or more likely to be heavily influenced by comorbidities like obesity and COPD and other things like
Yes.
that. What impact does that have on the image quality, and then what's the downflow impact on that on the accuracy of your subsequent flow model that you guys develop?
Yeah. So I mean, image quality is, is a huge one. And then say the quality is sufficient enough that we deem the patient included in the consideration. We are breaking down the comorbidities and looking at it as well. But I mean, looking at the shape and the flow, we can only draw so many conclusions from, okay, is this because they were diabetic or something else? So we can only report it. We can look at the specific subgroup analyses, break it down, what other differences do we find? Yeah.
Some patients
Like, well, quality, but also quantity. For some vulnerable groups, we need larger quantities to know more before jumping into conclusions. Yeah. Great. Any other questions? Thank you so much.